Welcome back to the course in Nuclear Medicine Physics. Today we're talking about different types of radiopharmaceutical therapies to treat cancer. Now, as you know, there's a variety of ways to treat cancer. You can give someone chemotherapy, you can surgically remove tumors, you can irradiate those tumors externally using a linear accelerator. Now, with radiopharmaceutical therapy, you inject someone with a radioactive molecule that travels through their body, binds to cancer cells, and delivers radiation directly at the tumors. In this lecture, we'll look at some of the advantages and disadvantages of this treatment and look at a few therapy outcomes.
Okay, so I guess this is my last lecture of the course, and we're gonna talk about radiopharmaceutical therapies and internal dosimetry. It's exciting. We've been building to this. I wanna thank in advance and acknowledge Dr. Anna Seller, Dr. Petra Skinas, and Julia Brosh, which is our postdoc now working with us. They provided some of the materials that I'm gonna show in this slide, so I wanna thank them for that. So let's start talking about cancer therapies. And we have different therapies for cancer. I guess the most common one, not the most common one, but one of those is surgery. When you have focalized cancer spots, physicians can go, they open the patient, and they will take out, for example, the tumor. We have chemotherapy, and chemotherapy uses chemicals that are injected in the body, and those chemicals kill cells, and we want to kill the cancer cells. Now, it has secondary effects. It doesn't necessarily just kill cancer cells. There are some effects from chemotherapy that hopefully you guys are familiar with because you've seen them around. But both chemotherapies, there are combination regimes. People test new molecules, or we find new targets. The maintenance regimes and multiple cycles of chemotherapy are applied, and that's up to the oncologist kind of to guide that treatment. We have also cytostatic treatments, which are, the idea of these treatments is to slow down or inhibit cell division. So they're more for long-term maintenance, and because it's slowing down the cell division, it's not really killing the cells, so the reduction in tumor burden is slow. There's also hormone therapy, which it's a way in which we either add or remove hormones to stop cancer growth. And again, we use for long-term treatments, and it can be used for multiple targets. There's immunotherapy, and immunotherapy is a way of, typically when there are tumors, ideally some of the cells of the immune system of the patient start recognizing these tumors, these cancer cells. So this is a way of trying to boost your immune system to fight cancer itself, and there are ways of doing that. I'm not an expert in immunotherapy, of course, but you can read more on that. Now we start getting into what I'm more familiar with, which are, for example, external beam radiation therapies or brachytherapies, in which now we're going to use radiation, and external beam, it uses fractionation schedules. So patient will come several times to the clinic, and in each of those sessions, a certain amount of dose will be given to the tumor, try to get rid of the cancer. And then there's intensively modulated radiation therapy, which, depending on where we're looking at the patient, we kind of change the shape of the X-ray beam. And there's also chemoradiotherapy, which, the patient can be having chemotherapy, but then also goes through some sessions of radiotherapy. Brachytherapy is a similar idea, but we have radioactive sources, but they're like solid sources. They're like, we call them seeds. And then these seeds are implanted in the patient around the tumor or the area that needs to be treated. That radiation will ideally destroy the cancer cells. We talked about that in the previous lecture. And regarding nuclear medicine, we have what we call radiopharmaceutical therapies. And this is, again, what we've been building up all in our course. And I want to thank Dr. Julie Rousseau for this very nice figure. But you think that you have a cell, and your cell has maybe some protein in the membrane. And we call that protein the target. We want to target the radiation to go to a specific site. So of course, this is very multidisciplinary. Biologists identify the targets, then chemists will create the pharmaceutical, which is basically a molecule. And the idea is that when we inject that molecule into the patient, it will bind to that target. So in this case, let's say this protein in the membrane, and this molecule will just attach to that protein in the membrane. So let's talk about prostate cancer, for example. We talked about PSMA, which is the prostate-specific membrane antigen. So all prostate cancer cells have one of these, which is the prostate-specific membrane antigen on the cells. Not other cells in the body don't have that. So that's one good target. We're going to target prostate cancer cells because we know that they have that protein. So let's create a molecule that attaches to that protein. And let's take that molecule and let's attach a radioisotope to it. So we also attach a radioisotope. So when we inject this radiopharmaceutical, it will bind to the prostate cancer cells, or to the cells that we're trying to target, and then the radiation will hopefully cause some effect and we'll be able to destroy the cancer cell. So let's compare that to radiation therapies. So in external beam radiation therapy, basically you have a source of X-rays that you move around the patient, but that requires knowledge of the tumor location. We need to know where is the tumor to be able to focus the beam on that tumor. In targeted radionuclide therapies, we inject, and what we need to know here is we need to have some knowledge about the tumor biology. And when you can see, for example, targeted radionuclide therapy can go more closely to the tumor. When we use external beam, we end up also affecting as X-rays go inside the body, while we're irradiating also some of the tissue that is not just the tumor. So what are some advantages of radiopharmaceutical therapies? Is that radiation delivery relies on the biology and the physiology. We can use the same molecule labeled with an imaging isotope, and an imaging isotope we can use this to diagnose, to stage, or to plan the therapy. Or we can have the molecule and label it with a therapy isotope, let's say like a beta emitter or an alpha emitter. And when we combine these two, the diagnostics and the therapies, that's what we call theranostics, which we have mentioned a little bit earlier in the course. Now, the main advantage is the radiation is delivered targeted to the tumors, even microscopic ones, even tumors that we don't really see. If there's one cell that has that target and the radiopharmaceutical attaches to that cell that we cannot really see very easy, well, we'll still be delivering radiation to that microscopic, at that microscopic level. Now, disadvantages is that, of course, well, we try to deliver the radiation only to the tumors, but there's also going to be some radiation not going to the tumors. There's also going to be some radiations in healthy organs. So if those healthy organs receive too much of that radiation, then we're going to have toxicity. And well, that's a non-desired effect. Well, at this point in time, it's still expensive, and the methodology, we're still working on it. It's still under development. We're still improving it. And at this point in time, again, personalized therapy planning and accurate dosimetry are rarely performed. I'm going to talk about that in a moment. These are some examples of radiopharmaceuticals that we use in this type of therapies. And well, there's a table there, but we use it for thyroid cancer. We use iodine for that, and the growth has been going up. We've used other traces for blood cancers and bone pain, which the current use is decreasing or is low. Now we have, for example, now lutetium-177 dotatate. Sorry, I'm missing a T here. We use this to treat neuroendocrine tumors. There was a radiopharmaceutical that has recently received FDA approval, which is that one, but is now marketed as Lutathera, and now it's becoming very popular. So its use is increasing a lot. And we have lutetium PSMA, which we use it to treat prostate cancer. And that's the example that I was giving a moment ago. And it's increasing a lot, and it's becoming like a very, very big thing for the treatment of prostate cancer. So yeah, it's becoming very popular, and it's bringing a lot of attention. Well, we've also used some tracers to treat lymphoma, and some microspheres to treat liver cancers. And this is not a complete list. There are more. These are just some examples, but just think that there are more and many, many of those radiopharmaceuticals. Now, this therapy, well, we can either deliver the radiopharmaceutical intravenously, so we would inject, or intra-arterially, depends on the one that we're using. For example, in the case of iodine, it's very common to use radionuclide capsules. So it's a capsule that has some iodine, the patient will swallow it, and then the thyroid, this is mostly used for thyroid cancer, the thyroid will uptake the iodine and will deliver the therapy. Or selective internal radiation therapies, and there is these yttrium-90 SIRT. So the way this works is you basically have like some microscopic glass spheres, and those microscopic glass spheres contain yttrium-90, which is a beta emitter. So for example, you insert it through an artery that goes to the liver, and those spheres just get stuck in the liver. So they're not circulating freely, like the radiopharmaceutical is not circulating freely in the blood. They're containing some glass, but then as the blood vessels start getting smaller and smaller, then they just basically get stuck there, and they get stuck close to the tumor. So that radiation, well, ideally kills the tumor. What are some therapy outcomes? We've seen this figure before, and this is PET imaging demonstrating the use of lutetium PSMA for the treatment of prostate cancer. So again, everything that you see in red is the first scan. Everything you see in red is a prostate cancer tumor. So it has been it's metastasized around the body from all these 8 patients. But after lutetium PSMA therapy, look, it has amazing results. It has successfully been able to remove most of the tumors in most of these patients. So that's why it's been so interesting. Now, let me just quickly mention something called the bystander effect, which is also an advantage of these radiation therapies. And when you look at tumor-directed drugs and toxins, they kill only the directed targeted cells. But when we talk about radiation, we've seen something that is recognized as the bystander effect, which is basically a phenomenon in which when you have cells in the vicinity of cells that receive radiation, these other cells also show signals as if they were receiving radiation, although they didn't. So there's some communication in between cells, and then you see those effects like cells in the vicinity of the ones that receive radiation also start dying, and they contribute to that genotoxic response to cell population. So those basically were eliminating cells that were not directly irradiating just because they were close to the irradiated cells. And that's kind of a big advantage. And we've seen that helps us a lot. So let's think, what's targeted radionuclide therapies? So this is what's happening right now. So all these therapies, in most of the situations, well, we know that each patient is different, but it's hard right now to implement a personalized approach to these therapies. And we're going to talk about that in a moment. But what we do then is that most of the patients are treated with the same amount of radioactivity. So of course, this is an empiric approach, and it has been chosen such that for the majority of the population, you don't really cause any toxicity. So that means you don't end up killing a healthy organ that then makes the patient more sick. So to try to not reach that toxicity, we come up with an injected activity value. But you can think then that we might just be leaving most of the patients undertreated, because if we're not reaching toxicities because we're keeping everyone well below the tolerated dose. I mean, maybe we have to still see. So they could probably tolerate a higher radiation dose. Maybe some patients will be able to receive a much higher injection, and maybe the outcomes will be better. So what I personally think is that optimal injected amounts of radiopharmaceuticals should be individually calculated, taking into account each patient's specific situation. And we're trying to get there, but there's still some paths to go. So we should probably create personalized and disease-specific treatment plans. We should establish an individual's minimum effective dose and maximum tolerated dose to tissue. So each person is different. Each person can tolerate more different amount of doses. We're trying to see if we can predict tumor and normal tissue response, and if we can predict toxicity before we even go and deliver the therapies. We still need some increase in the knowledge of radiobiology. And I mean, what we want to do here is we want this radiation to kill the cancer. So from external beam radiation therapy, we understand very well that certain amount of dose causes an effect. So if we deliver this amount of dose, we know that maybe that tumor is going to shrink by this much, and so on and so on. In radionuclide therapies, that knowledge, we still are missing some of that knowledge. We don't fully understand it because, I guess, mostly because of the dose rate at which our therapies get implemented. So we still need to understand more of that. And then we'll be able to compare the results of radiopharmaceutical therapies to, for example, the results with external beam therapies. But to do this, because this sounds amazing, there are, of course, some challenges that have made it hard to implement personalized dosimetry in the regular clinical workflow. So what we're going to do now is, well, I've been talking about dosimetry. So how is that we do internal radiation dosimetry? And as a reminder from the previous lecture, there's this Committee on Medical Internal Radiation Dose, which we refer to it as MIRD, formed in the 1960s. And this committee basically has worked on trying to standardize these internal dosimetry calculations. And remember, dose is measured in joules per kilogram, and 1 joule per kilogram, we just call it a gray. What I'm gonna say in the next slides are just a very small synopsis of all the details, but that's why I'm giving you here some references. But if you see, I'm citing the MIRD, which is that committee. And every once in a while, they release pamphlets that help us guide what we do. So for example, pamphlet number 11 was released in 1975, and they talk about absorbed dose per unit cumulative activity for some radionuclide organs. Most recent one is pamphlet number 26, which talks about guidelines for quantitative lutetium-177 SPECT. There are pamphlets that suggest how can you make dosimetry using SPECT. Some others are how can you make dosimetry calculations using voxelized approaches.